This evening, we'll be discussing an important and timely aspect of one of our bread and butter issues, patient care. When it comes to the treatment of serious mental illness, for the past decade, our journals and meetings have been largely and successfully focused on the care of individuals experiencing a first episode of psychosis. Major NIH initiatives, including RAISE and EpiNet, have demonstrated the risks attached to the duration of untreated psychosis and the promise of coordinated specialty care for aggressively treating early stage disease. But what happens next for individuals with these typically chronic and lifelong conditions? Let's find out. Now, to introduce tonight's distinguished speaker, I am delighted to welcome to the virtual podium a star of Northern Virginia neuropsychiatry and of the WPS CME committee, Dr. Colleen Blanchfield. Take it away, Colleen.
Thank you very much. Thank you very much. Yes, we all know there is a distracting echo. Mike, the presenter does not have an echo, and we have tried many times to get rid of it. So, Michael, my introduction is going to be truncated because it bothers everyone to hear this echo. Dr. Knabel received his undergraduate and medical degrees at Ohio University, trained in psychiatry at St. Elizabeth Hospital, and in neurology at George Washington Hospital, and is certified in the American Board of Psychiatry and Neurology, and is one of the very true neuropsychiatrists. Dr. Knabel was a clinical associate at the National Institute of Mental Health from 92 to 98. His research focused on severe mental illnesses. He was then the medical director of the Stanley Medical Research Institute from 98 until 2008. Dr. Knabel is well published and an author of over 80 publications on various aspects of neuropsychiatric diseases, including surviving manic depression, a manual on bipolar disorders for parents, families, and providers. Dr. Knabel serves as an assistant clinical professor at George Washington University, and currently he's the medical director of Clearview Communities, which is a lovely 32-bed therapeutic community for young adults with persistent mental illnesses. It is located in Frederick, Maryland. Dr. Knabel, we are very fortunate to have you with us tonight.
Thank you so much, Colleen and Matt, for the nice introduction and the invitation. I was not experiencing an echo. I hope others are not hearing an echo from me. I hope it's working okay. Well, I'm very happy to speak to the WPS and to be a newly returned prodigal member of the WPS. When I first went to set up Clearview in about 2010, I switched over to the Maryland Psychiatric Society. And then I realized I could get back into the WPS by using my home address. And I was very happy to do so because during that period I was away, the WPS has changed dramatically for the better with such great services for its members, great programs. I've been going to a lot of the CME programs and meetings, and I think it's wonderful. So I'm going to speak about long-term care, residential care for serious mental illness in my role as medical director of Clearview. And I'm also going to touch on some policy issues that affect long-term care in my role as board member of the Treatment Advocacy Center. Specifically, the availability of beds, insurance reform, and a little bit on the need for consistent and humane involuntary treatment for patients who don't recognize they're ill. My financial disclosures, I really have none. I'm an employee of the Sylvan Herman Foundation, which owns and operates Clearviews. Both of these are nonprofit 501c3 entities, and I'm a voluntary board member of the Treatment Advocacy Center, which is also a 501c3. So the question, which I think people have been discussing this for maybe at least since the Industrial Revolution, maybe before. How should we care for people with severe mental illness? And in 1955, the United States had 337 per 100,000 population in inpatient psychiatric beds, mostly in state hospitals. And in 1955, the census of St. Elizabeth's was over 7,000, which is about 900 per 100,000. And when I worked at St. Elizabeth's and in 1955, it was a federal hospital, so they weren't drawing patients just from DC, but they were drawing them from the military and from other places. And then I'm sure you've all heard a lot about deinstitutionalization. In 1963, John Kennedy passed the Community Mental Health Centers Act, which was the last piece of legislation he sponsored before his assassination. When I came to St. Elizabeth's in 1987, there was still about 4,000 patients there. And today, the census of St. Elizabeth is less than 400 patients, which is about 60 per 100,000. So the question is, what happened to those other people that used to be in long-term state hospital programs? And I would argue that, the legislation put forth by President Kennedy was very noble in its intention, but various other politicians kind of glommed onto the idea as a cost-saving measure, and we put people out in the community before we were really prepared to take care of them and to offer them the services that you see in EpiNet or with coordinated specialty care, or in very good residential programs. So, one academic effort that is going on but is still in its infancy is trying to figure out how many beds do we actually need. And like in other areas of medicine, people frequently start with surveying a group of experts, and there's a few publications on this. One publication from 2022 that surveyed 65 experts in Europe and the United States came up with the number. It should be about 60 per 100,000. That would be optimal, and 30 per 100,000 would be minimal. The Treatment Advocacy Center, where I work sometimes, convened a panel of 15 experts. They came up with a number of 50 per 100,000. There have been some very sophisticated mathematical modeling studies. One that I have not mentioned here came out of Duke. I don't have it on the slide, but it came up with similar numbers. But in mathematical modeling in California, at least, they came up with a very similar number, 50 per 100,000, 26 per 100,000 subacute. I would consider the work we do at Clearview sort of a subacute environment. It's staffed 24/7, and it's almost as controlled as a hospital environment, but not quite. U.S. national estimate, this paper from Hudson, which was published in 2021, came up with a lower number, 35 per 100,000, and an international modeling study published in 21 came up with 45 per 100,000. And TAC, the Treatment Advocacy Center, regularly studies this issue and gives an estimate of the number of beds in the states and around the country. And the most recent study was done in 2024. DC has 314 non-forensic beds, or somewhere around there, which is 44.7 per 100,000. Maryland has a despicably low number at 6 per 100,000. Virginia a little bit better at 19.8 per 100,000, and the U.S. as a whole 18 per 100,000. I've shown this slide before to groups in DC, and they're always surprised to see it because the number 45 per 100,000 is pretty close to what people predict. But most people I talk to say that they don't think the system is working that well. The chronically mentally ill are still jostled around and not given consistent care. So obviously, bed number is not the only factor that leads to good quality care for these folks. And I think, one advocacy issue that's important across the country is trying to figure out how we can get long-term hospital beds back in function. In most states now, you can't get into a state hospital without committing a crime, and so therefore we have a lot of people who are homeless or incarcerated. Furthermore, schizophrenia is as you all know, chronic and unpredictable condition. And these are the top reasons why people are readmitted to hospital within 30 days. So readmission rate within 30 days is a top quality indicator for Medicare reimbursement and Medicare certification of hospitals. And they want to see for each hospital that this number is going down. But the last data that I could get on this were from 2014. And you probably would not be surprised by congestive heart failure, respiratory failure, alcoholism, and various blood disorders. But schizophrenia, the number's about 23%. So that means 1 out of 4 patients with schizophrenia that are admitted to the hospital are back again before the end of the month. And I think that indicates the need for more coherent and available long-term care in the community. It's not really good for anybody to be readmitted so many times because, people don't really know your history, and people tend to kind of change things around that may or may not be in the best interest of the patient. Now, one of the reasons, there are a lot of political reasons for this, but one of the reasons in the private sector is that insurance companies have been lax in wanting to pay for quality care. And the Mental Health Parity and Addiction Equity Act was passed in 2008. It was sponsored by Patrick Kennedy. And it stated that health plans should provide equal benefits for mental health and substance use disorders as they would for chronic medical illnesses. So now it's 17 years later, and there's a ton of litigation going on about this issue. And we've made some progress, but the United States continues to face a mental health and substance use disorder crisis with persistent disparities in coverage for these conditions. In fact, a study published in 2024 last year found that 10% of adults and about an equal percentage of children have private insurance that does not cover mental health at all. And Obamacare allowed young people to stay on their parents' insurance until they were 26, which meant that we could get commercial insurance, for example, to pay for services at Clearview. But the Trump administration has announced that they will not enforce parity rules, at least at the federal level. And we've seen that insurance companies are starting to make it harder. We had about 15 years where we had very good relationships with insurers, and they would pay for long-term treatment for our patients, but now it's starting to get difficult again. I don't know if it's because of the Trump administration or something else, but we're involved in litigation as well about this issue. And if you want to learn more about the legislation or contribute to an advocacy group that's working on it, I have the Kennedy Forum's website listed there. Maybe you all know about them already, but I think they're quite a good organization. This is another organization, RTI International, and they were given funding to do a study on access to care by the Bowman Family Foundation, which is a New York foundation that I've also had some interaction with. And RTI International was tasked with evaluating barriers to behavioral health services among individuals with commercial insurance. They looked at claims from 2019 to 2021, covering 22 million individuals in all of the states, including coverage under PPO, HMO, and other plans. And I have a link to the full report if anybody wants to look it up. But what they found, so this applies not just to the severely mentally ill, but people in general seeking psychiatric or psychological services. And what they found that patients seeking those services went out of network 3.5 times more often to see a behavioral health clinician than a medical surgical clinician, about 9 times more often to see a psychiatrist, about 10 times more often to see a psychologist, 6 times more often to have acute inpatient care, 20 times more often for subacute inpatient care. And in-network office visit reimbursement, which is a key lever that health plans use to encourage provider to be in-network. It was higher for medical surgical clinicians than behavioral health. So for a similar amount of time, medical surgical clinicians are paid 22% higher on average than behavioral health, 48% higher at the 75th percentile, and 70% higher at the 95th percentile. And physician assistants for a similar amount of time were reimbursed 19% more than psychiatrists and 23% more than psychologists. And this was a very good study that covered a lot of claims. And in the years that I was in private practice in DC, it was very difficult to be in network with many companies for reasons I'm sure you're all very familiar with. This is another group, another nonprofit that we are thinking of collaborating with, or at least making a donation to them. It's called Cover My Mental Health. And this is a web-based and app-based program that helps individual patients challenge insurance company decisions. The website, I think, is quite good already, but they're still kind of in startup mode. But it shows the patient exactly how to appeal, to challenge, and to ask for other opinions, and helps walk them through that process. So I've described the situation in the United States, and I've always wondered, like, I'm one of these people that whenever I go on a trip, I end up visiting psychiatric hospitals and trying to talk to people and see if things are better in other countries. And I think things are a little bit better in Europe, but not perfect. And I'm going to take a little historical detour here. This is a famous hospital, La Salpêtrière in Paris. It's been in existence since 1656, and I guess I would say that in Europe they have less of a problem with homelessness and incarceration than we do, mostly because they have a better safety net system for financing care, and because they tend to do better in preserving institutions like this one. They keep them going. So this hospital is where Philippe Pinel worked. And I like to show it since it's been operating since the 17th century. And in the U.S., we've closed, as I mentioned, most of the hospitals that were used for the treatment of chronically mentally ill. Most people on this call probably know about this hospital because it was also the home of many famous clinicians, such as Charcot, with whom Freud studied, but also de la Tourette, Babinski, Duchenne, and many others. And one interesting fact about this hospital was at the time of the French Revolution, there were about 10,000 people living there. And they weren't all psychiatric patients. There was probably a pretty equal mixture of mentally ill, indigent, homeless people, and prisoners. It was also a prison. So the number of beds available for mentally ill people is less, but they do have it's now sort of a general hospital, but they have what they call a brain and spine institute, which includes long-term inpatient care for psychiatric patients. That's me in the picture on the right, standing under a statue of Philippe Pinel, trying to channel his idealism and fortitude in the face of difficult challenges. And also to show everybody the kind of backbreaking research that I have to do to make these slides. This is a famous painting of Pinel. It's by Tony Robert Fleury, and it's a picture of Pinel at La Salpêtrière. And it was claimed that he was one of the first physicians to regard mental illness as a medical problem, and many of these patients were tied up in chains or shackles. He sought to release them. He made rounds every day and would see as many patients as he could, and he would take copious notes about what happened with the patient, which led him to publish a book about the classification of mental illness. But also, surprisingly, he noticed that just by talking to the patients every day, some of them got a little bit better. And he published his book, A Treatise on Insanity, in 1806, which contains this quote: "He gives himself up to all the extravagances of maniacal fury, or sinks inexpressibly miserable into the lowest depths of despondence and melancholy," something we would probably recognize today as bipolar disorder. Pinel was, influenced by the ideas of the Enlightenment around the time of the French Revolution, and he could be considered the beginning of so-called moral treatment, which contemporaneously in England was being developed at this other place I visited called the York Retreat. It was founded by William Tuke in 1796, originally as a place for Quakers, not unlike the Quaker hospitals that were being built in the United States. But one of my favorite quotes from Samuel Tuke, who was William's son, is printed here. It says that regular employment is perhaps the most generally efficacious, and those kinds of employment are doubtless to be preferred both on a moral and physical account, which are accompanied by considerable bodily action that are most agreeable to the patient and which are most opposite to the illusions of his disease. So the idea of moral treatment, I think, still has relevance today. It was sort of the predecessor of the idea of therapeutic community, which is that we try to make institutions that are in themselves calming, interesting, stimulating, and offering activities to the patient, even if we cannot get their symptoms to go away completely with medications and other types of therapy. The York Retreat, incidentally, is still in existence, but I visited there in about 2012, and in 2018 they stopped providing inpatient care, and now they provide sort of intensive outpatient services only. This is just a couple more of these. This is St. Anne's Hospital, also in Paris, founded in 1651. Originally a general hospital, and the grounds were used as a farm for the psychiatric patients at Bicetre Hospital, which was nearby. The farm became very successful and profitable, and in the 19th century an asylum for psychiatric patients was built on the grounds, which is still in operation today. And it was at this hospital that Thorazine was discovered in 1952. And in the 1960s, this is similar to what happened at St. Elizabeth's, it was decided that patients working on the hospital grounds, either on the farm or in laundries or in other occupations, was a civil rights violation, and that type of work was disallowed in most countries. Finally, this is William Whitney Godding. He was the second superintendent of St. Elizabeth's from 1877 to 1899. I wrote a paper about him about 10 years ago. It was published in the Psychiatric Annals, and he was a very interesting man. He took over as the second superintendent, and he expanded the hospital from 3 central buildings housing 700 patients to 60 buildings, including cottages, very reminiscent of the therapeutic community idea that was eventually housed 2,000 patients. And Godding's son, Alva Godding, also worked at St. Elizabeth's, and he was the superintendent of the grounds and a horticulturalist, and he worked there until 1949. And when I came there in the 1980s, the grounds of St. Elizabeth's was still quite beautiful, and it was full of exotic plants and trees, and it was very pleasant just to walk around, especially on the western side of the campus, which now has been turned into the Department of Homeland Security, and a lot of acreage that was meant for the care of the mentally ill has been turned into use in other purposes. So this is a slide about residential programs for severe mental illness it's supposed to say the DMV. I don't know why it says the DW. And there are not that many. Shepherd Pratt, of course, is the biggest player in this market, but you can see they have 27 beds in Towson, 15 beds in Frederick, and then they have the Retreat, which is more like a private pay inpatient unit. and the total is less than 100 beds. And all three of these programs have length of stay under 2 months. So the goal of most commercially funded residential treatments is to give the patient a little bit greater stability coming out of hospital and then to discharge them into full outpatient care. And for the kind of patients that we treat, which in a former generation would have been in state hospitals, 1 or 2 months is not enough. There's Discovery Mood and Anxiety program in Annapolis with 48 beds. And in Northern Virginia, there's a program called A Mission for Michael, which is part of a national chain and has about 48 beds. Trying to estimate the number of residential beds in the public sector has been very difficult for me. And I've been thinking of that maybe I could work with some of the advocates in the WPS to use like a Freedom of Information Act type thing to find out from the Department of Behavioral Health what they actually have. I sit on the Mental Health Commission in the DC Superior Court where we review the cases of involuntary treatment. And I could say that some of the core service agencies and their residential programs are quite excellent. And then there's quite a number of them that are not excellent. But just trying to figure out how many beds there are and whether or not we have adequate services in our community is an open question in my mind. Now I will turn a little bit to talking about our own program, which Colleen mentioned is up in Frederick, and we have 32 beds for residential care. We have a campus that has 2 buildings housing 8 residents. We have some buildings that are in the community, regular houses in the regular community, 3rd Street and Norva. We have an 11,000 square foot office building where the therapists and psychiatrists, nurse practitioners are located. We have a 7,800 square foot fitness center with personal trainers, basketball court, and some other offices. We have a greenhouse for therapeutic nature work, which is probably our most popular program amongst the patients. And we also have what we call supported living services, where the patient lives in an apartment, either alone or with roommates, but continues to receive PHP or IOP level services in our offices. And these are what Colleen has visited. Colleen came up and gave a talk to us recently, and these are what the buildings, the newer buildings were built in 2016 and added on to some buildings that were made in the 1920s that we were required to maintain under historic preservation. This is our office building. These are what the residences look like. Everyone has their own room, their own bathroom, and then very attractive common areas for dining and recreation. This is one of the houses we own in Central Frederick that also has room for 8 people. This is very popular with the residents because it's in walking distance of most of the businesses in Central Frederick, so it's easy for them to work and to go to coffee shops and restaurants and things like that. So we take a pretty careful look at people before admitting them. We do a very kind of structured interview for diagnosis. We have personality and projective testing, which we do quite frequently because we get a lot of diagnostic conundra. Frequently families come just for that reason. Their son or daughter has been given 8 different diagnoses along the way and nobody's quite sure. They're on 12 medications, they have 8 diagnoses, and nobody really knows what's going on. That's quite common. Everybody gets the R-bands, which is the repeatable battery for the assessment of neuropsychological status. That's kind of a screening psychological testing to see where we are in terms of cognition. But we also have full battery of WAIS and neuropsych testing when we need to get that. All the patients get monthly rating scales. We use the BPRS, the MADRS, and a scale that we invented called the Community Integration Scale, which tries to quantify how much time people are spending out in the community, how much they're getting paid, and the number of hours they're working, and those things are added together to make a number for this scale. When the patient's admitted, everyone has an individual therapist and a lot of different group therapies focused on illness education and psychoeducation techniques. Maybe our most important tool is supported employment, and this is different from vocational training. This means that we have a relationship with a large group of employers who have agreed to work with us to resolve difficulties when the patient has problems. So rather than the patient being dismissed, the employers have agreed to work with us to mediate problems and to improve skills so they don't lose their job. I already mentioned individual and group psychotherapies, which for many patients is daily, sort of like in the old days of Chestnut Lodge, but for most patients is 1, 2, or 3 times a week. We have substance abuse counseling. Another very important program is occupational therapy, which I sort of underestimated the importance of that in my previous years working in hospitals. But we have many patients that come to us and they don't know how to wash their clothes, they don't know how to prepare meals, either because the family has been trying to protect them from illness or because of their own cognitive and reality testing problems. They just don't know how to do basic skills, so occupational therapy works with them on that. We have computerized cognitive remediation. Of course, we have psychopharmacology, a wide range of recreational and wellness activities. We've been thinking about setting up a completely separate program for people with metabolic syndrome, which almost all of our patients have, either because they're very sedentary or because of the effects of medications. They tend to be overweight, have hyperlipidemia, and insulin resistance and related problems. I wanted to say a few more words about supported employment. I love these historical quotes. The first one is from Galen, which was written in 172 AD. Employment is nature's best physician and is essential to human happiness. And then from Sigmund Freud in 1930. Work has a greater effect than any other technique of living in the direction of binding an individual closely to reality. In his work, at least, he is securely attached to a part of the reality, the human community. And we've come to feel that work is the best laboratory for practicing skills that people learn in psychotherapy. You have to learn to meet your commitments, your responsibilities. You have to learn how to get along with difficult people. You have to learn to tolerate distressing situations. And we introduce the patient to it gradually, starting sometimes with 1 hour a week, and then slowly working up to 20 hours a week, and then hopefully eventually they can work full time. So we opened about 14 years ago, 2011. We've treated probably, this slide is a little bit out of date, close to 300 patients now that we keep very detailed statistics on. On average, they're 25 years old when they come. Our mean length of stay is 12.3 months. 65% of our patients are male, with a mean duration of illness of about 12 years. So many of them have been ill since childhood. Mean number of hospitalizations before coming to us is about 5. And the mean R-band score is 79. So this is scaled sort of like the WAIS, with 100 being the mean. And our average is right around 80, which is more than one standard deviation below the mean. So you can see from this slide that we're talking about a chronically ill, frequently treatment refractory, cognitively impaired population that needs a lot of support from other people to have a chance at rehabilitation. Our population is about half and half schizophrenia and mood disorders, 47% schizophrenia up until now, about 20% treatment refractory unipolar depression, 25% bipolar, and 10% other. These are the other is usually autism spectrum or PTSD, trauma-related conditions. Occasionally, we will take a patient with OCD, but in general, we're focused on kind of chronic psychosis and mood disorders. About a third of our patients have a comorbid Axis 2 diagnosis, most of which are borderline personality, 14% other Axis 2 disorders. So this is where we have a great need for DVT and similar techniques for emotional dysregulation and so on. We screen for substance abuse. People have to be clean for 30 days before they come to us, but 44% meet criteria for a substance use disorder in the year prior to admission. And this is a slide, so as people probably know, if you look at the population of people with schizophrenia in the United States, they tend to be more than 90% unemployed. But this is an average from 2016 to 2023, which we call our engagement rate. We are able to get about 42% in competitive employment. These numbers are not mutually exclusive, so sometimes people are going to school and working together, but about 13% volunteering and about 18% going to school. So we think this is pretty good that we get the number of people who are able to work and potentially live independently significantly shifted. We don't know how long this lasts for. We've tried all sorts of different techniques for tracking our patients down, including getting claims data from insurance companies and surveying the patients, but we never get enough data to make a conclusion. But we know at the time of discharge that we get about 42% to the point where they can work 20 hours a week at least. We still have a significant problem with what we call treatment failures. So everything is not totally rosy up there at Clearview. But by treatment failure, we mean the patient is discharged to the same or a higher level of care. They're discharged against medical advice, which means they leave, but we want them to stay. Or an administrative discharge, which means they want to stay, but we want them to leave. And usually because they have violated the rights of others, and to the extent that we can't safely keep them there, or death, which thankfully has hit, over the years we've had 2 suicides. But anyway, the average rate of treatment failures between 17 and 23 was 37%. So a lot of people come and don't finish the program, and we're trying to figure out what we can do about that. And a lot of it, I would say, is very intangible. It's usually because the patient comes and meets somebody that they really like. It could be another patient, it could be the yoga teacher, it's usually not me, and it's usually not the psychotherapist, but they somehow make a connection, and even if they have a very virulent form of the illness, they feel safe and they feel connected and they decide to stay. So we're trying to figure out how we can get better at that. We designed a scale to see if we could predict, this was largely at the encouragement of insurance companies, can you predict who will succeed in residential treatment? And we came up with a scale that has like 35 items on it. And those who are treatment failures have a score on average 33, and those that succeed have a score on average 22. But we never got the scale to have more than 70% sensitivity and specificity. So we've had people with scores above 100 that ended up doing great. And this is what I mean about the intangible nature of predicting this. But we continue to try to refine this to see if we can get the sensitivity and specificity a bit better. But that will require a larger sample and more time. I think a lot of the treatment failures are because of anosognosia. The patients are not, they are not aware that they're having problems relating with other people or interpreting reality. And we can't accept those people into voluntary residential programs at present. And when I wrote this slide, Maryland was one of only 3 states in the country that had no outpatient commitment statute, no civil commitment of outpatients. Now, a law passed in Maryland last summer that introduced legislation to allow for court-ordered civil commitment of outpatients, but it's not implemented yet, and we think we can treat committed patients, but it's not clear the courts will commit the patient to us or if they will have to go to a public facility. And so that's all getting worked out. The other two states are Connecticut and Massachusetts, in case anybody's interested. And the Treatment Advocacy Center has been the leader in this effort to get outpatient commitment statutes that are reasonably similar to each other and applied in a humane manner throughout the country. When I first got involved with TAC 25 years ago, there were 15 states with no outpatient commitment statutes, and now it's down to 2. Dr. Rudorfer referred to this NIH-sponsored study called RAISE, which was a study of coordinated specialty care compared to treatment as usual. 404 patients, funded by the NIH, began in 2008. And they found, with a treatment program very similar to ours, that there was a greater improvement in quality of life and psychopathology, greater involvement in work and school, markedly lower hospitalization rate. And as Dr. Rudorfer also pointed out, those with the duration of untreated psychosis less than the mean of 74 weeks did much better. I've sort of lost track what's going on with coordinated specialty care and EpiNet because I think they were largely funded by NIH and SAMHSA, which I suspect have been cut in the current administration, but I don't know for sure. But the EpiNet program was quite a good program all around the country, trying to treat people early in the course of illness and accomplish similar goals to what we're trying to do. This is my last slide, so leave time for some discussion. Tom Insel was the head of NIMH, and he's a colleague, and I have great respect for him. But I like to show this quote that he made. Maybe some of you have seen it before. But when he left the NIMH, he said these words: "I spent 13 years at NIMH really pushing on the neuroscience and genetics of mental disorders. And when I look back on that, I realize that while I think I succeeded in getting lots of really cool papers published by cool scientists at fairly large costs, I think 20 billion, I don't think we moved the needle in reducing suicide, reducing hospitalizations, improving recovery for the tens of millions of people who have mental illness. I hold myself accountable for that." And I and others have been somewhat critical of the NIMH research portfolio, which is more than 95% basic science, and would argue that some balanced approach to improving clinical care is also a good idea. And just in the red at the bottom, just as a side note, $20 billion is enough to start 5,000 programs like Clearview, and there are 3,144 counties in the USA, so you could envision a day, if we had the leadership in place, that would sponsor long-term programs all across the country for much less money than is being spent currently. So I think that's my last one. Yeah, that's my last slide, so I'm happy to answer questions or discuss with you any of these ideas.
Thank you very much, Michael. That was excellent. And we do have one question from participant. Adelaide Rob is wondering if you take young adults with autism who are verbal. Maybe you want to say a little bit about what's in that other category.
So we take most of the patients we take are 18 to 30. They have to be old enough to provide informed consent, so they have to be adults. And we like to take people younger than 30 because we feel like we do much better with them if they're still in the early phase of illness. For people with very, classic and severe autism with speech delay, cognitive impairments, neurological comorbidities, we tend not to take them. We have found that the environment is too overstimulating for them, and they tend to maybe end up with more problems than they came with. For people who are on the spectrum and have less severe versions of autism and who have normal language and speech, we have done very well with them. We haven't treated a lot of them, but we do usually have a few at any given time. So if by young adult you mean above 18, then the answer is yes.
Yeah, we just I echo too, apparently. We have a lot of kids who are higher functioning, make it through high school. And then when the supports at age 22 are gone, they can't transition to college. They can't ride the subway. They can't get a job. They can talk and they perseverate on topics, but they can't function in the real world.
Well, they have great difficulty with social interaction, and we have social skills training that can help many of them, as it does for people with schizophrenia. But they have to be in the higher functioning realm, as you point out. Yeah.
Well, Michael, thank you so much. It was
My
an
pleasure.
excellent presentation, has all of us thinking in a different way, as we do a lot of scientific presentations on the basic sciences and neuroscience, but this was excellent.
Thank you.
And I really enjoyed your community when I was there.
Thank you. I invite anyone who's interested to come and take a look. I'm happy to show you around and have lunch with you if you want to come up.
Michael, I'd like to add my thanks and mention that EpiNet is still alive and well-ish. These are uncertain times, but the EpiNet program does exist at a number of centers across the country. Again, focusing on early stage psychosis. And if I could ask you a question, you mentioned in passing the reference to intensive outpatient treatment. I mean, do you, especially given the dearth of inpatient beds, I mean, do you see that as playing a significant role?
It's actually kind of a complicated question. We're thinking of expanding by building apartments that the patient and family pay for so that the insurance company doesn't have to pay for housing, and having sort of a PHP level of care that those patients can attend. But what we have found is when we discharge a patient to a PHP, it almost never works because they think, I have to start over again with groups and individual therapy, sitting around in a room, talking to people about how I'm feeling, and what I want to do is live in my apartment and keep my job. And so I think if we develop IOP or PHP more fully, it would be a little bit different from the classic model, where we're trying to mostly keep the patient focused on engagement in the community and not necessarily requiring them to sit in group therapy all day. One other thing about EpiNet that I wanted to mention, that one thing I do know about it is that the AMA recently admitted some insurance codes for coordinated specialty care. CPT codes for coordinated specialty care have now been published. That doesn't mean the insurance company is going to pay for it, but at least we have codes now. Yeah.
Okay. It's always good to see that research can hopefully have some effect in real world treatment.
Absolutely. Yeah.
Okay. Are there further questions, comments?
There's one more question. It says to Dr. Rudolph's question, what part do you think acute crisis centers with residential beds could play as well?
Is that for me or for Dr. Rudolpher?
I hope it's you.
Well, That's also an interesting question. The insurance companies are sort of leaning in that direction. My personal experience is that for these kind of patients, it doesn't work. I think if our treatment doesn't work, we try to help the patient and their family get into the public sector and public services. But if you have a crisis bed and then you discharge that patient back home or to an environment that doesn't have daily contact and daily support, they always relapse. And my own philosophy, and this is maybe not based on data, but my own philosophy has become everybody deserves a chance at rehabilitation that should go on for about 2 years. And if it fails, then we should be able to send the patient to a high-quality public program where the focus is more custodial. It doesn't have to be residential. It could be ACT team-based or, kind of more frequent contact as an outpatient. And the patients we treat are very ill, and they can't really be rehabilitated without, all of these people working together to help them. We have about 100 employees, and everybody is focused on getting that patient to learn to be independent and to work. It doesn't always work, but I think everybody deserves a chance.
Agreed. Agreed.
Okay, and I don't know if you're accepting any volunteers to help with that backbreaking research in Europe, but we'll pass any names along.
Okay, well, I've heard that we need to make a survey of the Caribbean hospitals, so maybe we can do
there
that.
You go. Okay, well, thank you again very much for a very informative and very thought-provoking presentation.
My pleasure. Thanks to all of you.
Okay, thanks everyone for attending. Happy holidays, and we will see you back here the second Wednesday of January, 2026.